Let's see.
Okay.
Oh, hi.
There.
Okay, it's 9 o'clock and I'd like to call the meeting to order for the Neighbors of Dunn County Committee meeting here on May 25th, 9 a.m. And as I look around, there are three of us, Supervisor Keeter, Supervisor Witzel, and myself, and no one on Zoom at this time. Supervisor Bjork has a doctor's appointment, and I haven't heard from Supervisor Breslin. So starting off, that's the roll. Approval of the minutes. Chris sent out revised minutes. And any corrections or comments? And I would entertain a motion to approve them. Supervisor Keeter moves and Corley, Supervisor Witzel seconds. All in favor? Aye. It passes. Is there any public comment, Carmen?
No.
No public comment. We have Dr. Brown joining us, and I invite you to come up to the table. And at the request of the chair, there is none. So we go right to you, Carmen.
All right. Thank you, Supervisor Kinnear. All right. As always, the Quality Assurance Steering Committee is our first update. The only thing new this month is that we did have our new pharmacist with us. Same company, our pharmacist had just retired. So our new pharmacist that was assigned to our building from our pharmacy company was there in person. So that was nice. He actually has worked at the Neighbors before in the Dunn County Healthcare Center, just through a different company before we switched to our current pharmacy company. So he is familiar with our facility as well as several of our nursing staff. So that is helpful too, a little bit less of a learning curve of how things work. So, and that was really the big thing for QA. We went over some COVID related changes and we had a couple of staff reports, but nothing, anything notable or different. Any questions about QA? All right. Next is the employment activity report. So I will have Chris, who is on remotely.
Good morning.
Hi, Chris.
Hey, so the April employment activity report was in your packet that was sent out. And go through the number of interviews. So we had 6 direct hire interviews, 8 agency interviews. We had 6 positions offered, 6 were accepted, 4 with May start date. So kind of throws it off a little bit. It's some resignations as usual. Part-time CNA, no return from school or no contact. I think she's working in the city that she's going to school in for the summer. We had a full-time RN that left, and then a part-time homemaker and a part-time food service worker graduated from college, so they found other employment within their field of study. We go down to open positions; those were adjusted with the leaving and people being onboarded. Work comp lost hours. We didn't have any lost time for the month of April. And the number of missed shifts in April due to COVID-19 was 30 shifts, or roughly 240 hours. I'll circle back. I don't know if anybody noticed, but I did leave the leave of absence information off of there. With our students coming back, we really only had a couple on there that were medical leaves, and I don't feel comfortable signaling the medical leave people out on our report, so I just left it off of there. If anybody has any concerns with that, we can relook at that. But from an HR standpoint, I just didn't feel comfortable having that on there for that.
You done, Chris?
Yep.
Oh, okay. First off, it's nice to see you without a mask.
Well, thank you.
Uh, Now, one of the problems of only meeting once a month is we forget things. And I do that all the time. So when we look at open positions there, for example, RN 12 total positions, does
Yep.
that mean that we are short 12 positions?
Yes, of the majority of the RN positions that were short are filled either with agency, an RN from agency, or more than likely agency LPNs. And this isn't even right now because there's always movement. So I think we have maybe 5 or 6 agency LPNs at this time. In real time is what we probably have. At the time this was captured for April is what we had. You'll notice that like the last month, the open positions were like 16.5 FTEs. I just combine them into total positions. So the 12 total positions that are open are a mix of full and part-time. It just got too muddy with, who left that was a 0.2 or a 0.1. So I just did total vacant positions.
Okay, and when it says one position filled with agency, well, what about the other 11?
Yep, we have one agency RN.
So there's LPNs helping fill some of those positions as well.
Those hours, yep.
And the 12 total positions or the 11 and all of those is if we were fully staffed. So that is the total number. So that is if we had all 9 households open as well.
Okay, so we have 7 nights open now.
Correct.
Okay, so there'd be 9 total positions perhaps, in a way,
Sure. Mhm.
but they're all filled somehow.
Filled as much as we can, yes. So that is, they're either filled by agency staff or if people are picking up as well. So if someone's FTE is say like a 0.2 and every other weekend, they might pick up shifts during the week. So they're filling some of those open FTEs by picking up extra shifts as well. Because we do have a couple of nurses who are only scheduled for every other weekend, but then they pick up shifts if they would like. So they fill in some of those positions as
Okay,
well.
so for example, the CNA, Chris, you just said 37 total positions. That doesn't mean FTEs. That just means 37.
Total positions. It's a mix of
Okay,
0.6 and 0.4 and so on and so forth.
So they're filled with agency or if we can get somebody or people filling in,
Or people picking up, correct?
but they are filled.
Correct.
Yep.
And I may ask that again in 3 months, but it takes a while. Thank you very much. Any questions on that? Yes. Put your,
Just to follow up on that CNA, you have 37 open total positions, 23 positions are filled with agency. So then you have no CNAs that are full-time employment or?
No, we do have CNAs that are full-time employment. So those are just the open positions. So there would be all the other positions that are filled with employment with either full-time or part-time. Internal staff aren't listed there. So those are only the open positions.
Oh, okay.
And kind of on a positive note for May, I know this will be reported again in May, but we do have on the 31st, 3 hired as of right now. I have an interview this afternoon, so potentially 4 CNAs starting May 31st.
That are internal staff.
That are internal, correct.
That's good.
thank you very much, Chris.
You're
And
welcome.
thank you for updating the minutes. I had expected you to do it for next time, but you're way ahead of me, so thank you.
Yep, you're welcome.
All right, next is the CNA training program. So my only update for this is I had been emailing with the director of the course that has, would be another company coming in for us this week. And I resent her some plans. Part of the reason that the state was questioning our plans was because if they use the current classroom that we have in Arrowhead, they were saying that that is currently an active licensed bed, which it is. It is technically a room that could be filled with residents. And they wanted a certification that it hadn't been filled or wasn't planning on being filled. So I gave her an updated plan and kind of some background information. Later on in the agenda, I guess I could have put these next to each other, but I have the 2024 census to have a discussion about plan for budgeting, and the board's idea or the committee's idea of what we should plan for census for 2024, because that does drive how we budget. And we're working on that diligently for next year's budget. But what I did explain to her is that there's a likely chance that we will budget Arrowhead to be closed in 2024 if we're budgeting realistically. And that would mean that there wouldn't be residents in those rooms. Because the concern is that the classroom is set in an area where it would disturb residents currently living in that area. So I did explain to her that that is not the case. They are licensed beds, but we have at this point no intention of filling them anytime soon, as we would fill Fireside first. If we got to the point that we could open up another household, we wouldn't start with Arrowhead. And likely our budget for 2024, budgeting realistically, would have Arrowhead not open. So hoping to get a response back on that, as that would be the easiest use of that space versus using the house, as the house would require construction. That would then also inquire some cost. So it would be much easier to use the space that was already designed for the classroom. So.
Questions? Now, is that the state that's the problem or the agency?
The state, so the state has strict, I don't know if that's a word, made it more strict, to have a classroom in resident areas, trying to make it more resident-centered care, that we don't disrupt them. They have to have a separate entrance, things like that, which we would have, even if there was residents there. But technically speaking, if Arrowhead was open, the classroom is right next to a resident room, which is what they were having issues with.
Okay, thank you.
All right, next is a resident referral report. So that is on the other, in the packet. So at the beginning of the month, we had 99 residents. We had 60 referrals. So we're actually coming down a little bit from when we were seeing hundreds of referrals. We had 8 residents admitted. We had 52 not admitted. We had 101 at the end of the month. We had 1 resident transfer to another facility. She moved to live with her spouse. Her spouse had been moved into another facility in Chippewa, and she wanted to go live with him. It was the VA facility, so until he was living there, she could not have VA access to live there, and now she is living there with him. We had 1 death this month, and we had 2 residents discharge home. And our referral sources were the same as usual, the 2 Mayos that are local, and then Sacred Heart in Eau Claire.
Questions? Comment on the person that moved, that person loved the neighbors
Very much so.
and for better or worse, you're married, but she really did love it. Now, 101, you can still cover that, and you're still thinking about that zero.
Yep. Mhm.
Zeroing out with it.
Yep. So
Most-
we have had a couple of admissions this week. We had, seems like it comes and goes in weeks. We had 0 admissions last week, and we've had a couple this week. So we're hovering right around the 100. So that's not opening any other households. It's still the 7. And if we're staffed, the staffing is the same for if we have 97 residents versus if we have 102 residents. It's just based on open beds. We still staff the same amount of CNAs and nurses if we have those 7 households open, whether they have 12 residents in the household or 14 residents in the household. We still need 2 CNAs.
Thank you.
Mhm.
Supervisor, Dunn.
What is your, I should know this, but what is your total capacity?
137 is the total.
37. So we're 37 below.
Correct.
Okay. That does make quite a difference, doesn't it?
Mhm.
In the
Yes.
bottom line.
Any other questions on resident referrals? Okay, and then Scott has the environmental and facilities report.
Good morning, everyone. From facilities, pretty much everything is as usual. Brady and Bob have been working on their work orders and been out mowing, taking care of the grounds. I know we have a crop of dandelions again. I do have plans of spraying some of that so that we can start knocking down some of the dandelions, at least in front of the buildings. Anything's looking better. Wednesday, May 17th, we had the annual disaster drill, which Carmen has next on the agenda, but I just thought I'd mention that things went well from facilities standpoint. Aside from that, everything pretty much has been business as usual. I did get information back on a bus from a company that I'll have to work through with Carmen talking about, so we can keep moving forward with the bus plans. I'll have a meeting with her and then we'll report that back probably next month. So.
Questions? Thank you, Scott.
Thanks.
All right, next, as Scott mentioned, is the annual disaster drill. So last Wednesday, we had our annual disaster drill. This is a federal requirement for all skilled nursing facilities to have a community-based disaster drill. So that means we do have to involve other community members that are like the fire department, the police department, sheriff, E911. To make sure that we are prepared as best as possible in case of an emergency where we would have to do an evacuation of residents. We do this every year. We typically have done this in the fall, which this year, with working with Scott's team, we decided to move to the spring as our most likely evacuation is due to tornado and severe weather. And if we're doing it in the fall, we're past tornado season. So we decided to move it to the spring. So we actually did this about 6 months earlier than when we normally do it. But we did do it this way just to prepare for anything that could happen this summer with weather. So what we do for the evacuation drill, if anyone had not been on the committee or does not remember, we do have to evacuate people from the facility. We do not have to include residents in that. We do volunteers right now. We had previously used residents. The residents have to be voluntary. We can't make them do it. Throughout the past few years due to COVID, we did not evacuate residents, as it does mean grouping people in small areas together, and didn't want to cross buildings and households and things like that. Hopefully next year, if things are still going the way they are right now, we'll get residents involved more next year. And we do have a plan to get them involved through the whole planning process, and hopefully more residents would be wanting to do it. Because in the past, several residents said, no, they don't want to. But it would make it a little bit more realistic if we are evacuating residents versus staff volunteers that are acting as residents. Through this process, we do evacuate people from every household on campus. We did the 7 active households. So there was 2 volunteers per household that were evacuated. We give them fake diagnoses and fake injuries and capabilities. So some of them might need 2 staff to assist them out. Some of them were bedbound and we had to tear down beds to get them out. Granted, in a real emergency, we probably would not be taking the time to tear down the beds. We'd be figuring out another way to get them out. But we did want staff to be re-educated on how to tear down beds. The history behind that is, as our beds, when they are fully put together, they do not fit through the doorway. They do if you take the headrest and the footrest off. They're just a little bit too wide to fit through the doorway, because we technically have bariatric beds so that they can fit heavier people, but they don't fit through the standard doorway. So we have to take off the head and the footrest to move through the doorway. So did that as a re-education for staff as well through that process. It went fairly well. We did have a new gentleman from E911. I think he said he had been here 10 weeks. So it was nice to have a fresh set of eyes look at our disaster plan, because we have had the same people come from all the different agencies every year. So it was really nice to get a new perspective, and he had some great ideas and some things that we plan on changing for the plan in the future to make it a little bit more realistic. And every year that gets a little bit better and we learn something new too. So it went fairly well. Any questions on that at all?
I was just wondering if, say a tornado is coming, where would you evacuate people to?
So it depends on the situation. If a tornado is coming, we actually have people, we have shelter in place as our first course of action. If we can, we will shelter in the buildings. So anytime we have a tornado warning in our county, we actually have places that are the most structurally sound in the facility are identified, and that's where all residents are asked to go. If a resident refuses, we can't force them to go there, but we do take people out of bed because typically tornadoes are happening in the evening, and we bring them to the safest part of the building. If the buildings were to be hit by a tornado and we're not able to remain in place, if it was just one building, which is probably unlikely because we're all in one line, we would evacuate to the other two buildings. If it was all of the buildings, the first course of evacuation is this building. So that is where we evacuated during the drill. Was we brought people over to this room actually. Disturbed Matt setting up county board, but that was a whole nother thing. So that would be our first course of action, would be evacuation here, and or the hospital, depending on what the situation is. Then we also are required to have contracts with other facilities that are outside of our county. And actually we are required to have a contract with a facility that is 50 miles or further away. Because depending on the natural disaster, it could affect a whole region. So we have contracts with two other county facilities that are, it's Clark County and Trempealeau County. So if they were in the same situation, we're one of their contracts that they would evacuate to, and we would evacuate to them. So in situations like that, we call them and we say, this is how many people we have to evacuate. How many can you take? And we send them there.
Thank you.
Any other questions on evacuation? All right, and I hope we never have to use that drill, but we are prepared in the case that we do. All right, next is Medicaid rate appeals update. So I believe last month I did mention that other facilities had received motions to dismiss on their appeals, and we had not. Well, coincidentally, we got the email with the motion to dismiss during the meeting last month. So we did receive that from the state. We have until next week to reply. We had gone back and forth about working with attorneys to do so. From our knowledge, the state did not grant the attorneys to do it as a group. And we are close to the deadline, so we are actually going to just reply on our own. The cost with the attorneys and the likelihood that the state is going to agree with us is not high. So it seemed not prudent to spend the money on the attorneys to fight for a marginal increase that we probably wouldn't make our money back. And that is if we even won the appeal. So spending money to potentially make a little bit more money, it didn't seem like the best financial choice, as we weren't anticipating the state's going to agree with us anyways. So we are going to still try to send a motion, or however you want to phrase it, to not dismiss and try to do it on our own, but not spending money to have attorneys do it also. So Jane has been working diligently to find every way through the cost report to negate the issues that have previously caused the rates to be low. So we are working on that. And then that'll be going forward as well to try to mitigate some of the issues that caused the lower rates. Any questions on that at all?
Oh, looks okay.
Okay, next is the COVID-19 update. Well, as you all saw, Chris did not have a mask on. So as of last week, also Wednesday, so last week was a busy week. We had nursing home week, we had the disaster drill, and we revised our mask policy at the neighbors. So I believe I mentioned it last month that due to the end of the public health emergency, we were anticipating there be significant changes to nursing home regulations, but they had not been released yet. Those were released the day of the end of the emergency. So we didn't have much time to prepare. But one of the things that was the highlight of it was the masking policy and the regulations regarding masks in skilled nursing facilities. Per the regulation, skilled nursing facilities are supposed to defer to their public health departments for guidance and a preparation of policies, as well as when masks should or should not be worn. So Sarah and I met with KT that day to go over some policies and some ideas of what we should do for masking, as the CMS and state regulations do not say we can just go completely mask free. It says you must mitigate risk. So that's also up to interpretation. So we worked with KT on that and came up with a fairly good policy, I think, that allows us to be mask free for now. But it does have in the implication that if public health does note a significant risk, that we would go back to masking during that time of risk based on public health. Previously, masking was related to county transmission rates, which was a rate that was publicly published that we could see and we could track. Those rates are no longer publicly published. At the end of the public health emergency, they stopped reporting those. So we don't have a good rate to go off of. So that's why we are going with public health's guidance. So our policy now for masking is we are mask free unless we are in an outbreak, which that would be one positive resident or staff of a household, which that is actually part of the CMS requirement. In general, outbreak requires masking in that household. So that one is not up to public health or facility interpretation. And then we'll be mask free until or if public health deems a significant outbreak in our community. So they base that based on hospitalization rates for COVID as well as water testing. So that is the two things that they use. So that might be a delayed response, but if they tell us we think that you should have masks on again, we are required to do that. And that would only be if there was significant county-wide spread of some version of COVID-19. Part of this policy also brings back some of our past flu policy. Prior to COVID, our flu vaccine policy was that flu vaccines were strongly encouraged. We did not require them necessarily, but then during flu season, anyone who did not receive a flu vaccine was required to wear a mask. This has been the policy for decades with the Dunn County Healthcare Center and NDC was if you didn't receive a flu vaccine just during that flu season where flu is prevalent, you had to wear a mask at the facility. We are continuing that policy to come back, as well as now it is known as the respiratory illness season instead of flu season. So it would be if you're not up to date on all recommended vaccines regarding respiratory illness, you would be required to wear a mask at work. That is only for staff. It does not include visitors or residents. Residents are not required to wear masks, nor are visitors. The only time visitors would be if we were in an outbreak.
So does vaccine include COVID vaccine? Okay.
It'd be any recommended respiratory illness vaccine. We made it broad as we were advised that RSV might be having a vaccine recommendation for a certain age group this year. So to negate having to change our policy for every different kind of illness or if a new illness were to come out, we made it so that it was all recommended respiratory vaccines. Besides the masking policy, that was probably the biggest one, but there are some other changes to COVID-19 related things. One of them is the vaccine itself. As part of the CMS and CDC changes that came out with the end of the public health emergency, vaccine mandates were part of that change. They still have not given out clear guidance through a QSO memo or anything like that from CMS directly at nursing homes. It was more of a broad vaccine mandate change, basically implying that the mandate for vaccines was going to go away. Basically, all that means for us is that we would no longer need to require exemptions from staff that did not want to receive the COVID vaccine. That was still kind of up in the air as they have not put out an actual rule on that yet. But it was included in the overall public health emergency ending memos, things like that. So we're still waiting on the formal word on that. It does not overly affect us that much at this time, as we still do have to track vaccines. So even if it is not required to be vaccinated or have an exemption, we still need to know everybody's vaccination status, as we are required to report it to NHSN, which is an overall reporting system for the CDC, which is a weekly report of all vaccines and then any cases of COVID as well. And then finally, testing is the other one we get a lot of questions about. Testing has changed slightly. We still have to require anybody with symptoms to be tested. We are working on a way to do that internally now that insurance companies are not covering it. So trying to help staff out on that, as through the pandemic, the insurance companies have covered COVID testing. And so when we sent someone to get COVID testing, it was typically free to them to do so. But anyone that has symptoms has to be tested prior to returning to work. Now that is not the case. All of a sudden, as the pandemic public health emergency ended, insurances stopped covering them. We don't want staff to have to pay large sums of money anytime that they have to get tested. So we're working on a process to do it internally at work, as we do have significant amounts of tests available at work due to the stockpile that we have. So we were working on a way to do that to benefit staff, so they're not paying large sums of money, as well as not coming to work sick because they don't want to pay the large sum of money. So also preventing that from occurring as well. Are there any questions on COVID related stuff?
It did seem like there's just a few more lost shifts this time than last time. It's just coincidental or when they're reported.
Yeah, that we did not have any outbreaks or anything like that. We had one positive staff member a few weeks ago was our last outbreak.
Okay, thank you. Looks good. And then the one that I was wondering about.
2024 census. So I included this on here as a discussion point, as Jane and I have been working on our budget for 2024. Seems a little crazy that we're already there, but we are. And one of the bigger questions that we have is what we should budget for census. So we've gone kind of back and forth on different ideas of census and wanted to bring it to the committee as a discussion item of ideas or thoughts on what we should do for census. There's been multiple avenues that we've gone in the past. I believe it was 2018, we budgeted a very conservative census. I believe we budgeted at 80% at that point. And then that happened to be, I think that was 419 maybe. And that happened to be one of our best years. And then we were technically over budget the entire year, but still in the black. So that added some difficulties. And then there's years like this year that we budgeted full, and we're obviously not hitting those budget targets as we have two closed households. So it does very much drive how we budget and how we budget expenses. We always adjust our expenses to census, the ones we can. So supplies, staffing, things like that, we adjust to census, but it does make a difference when we're looking at the overall year for a budget. So we have a few different ideas of things we could budget with. One of which would basically the two options that we were thinking is having one closed household or two for the budget. At this point, we don't think it is realistic to budget full, which we have done for a few years. In 2019, we were nearly full. It was our best year we've had in quite some time in terms of census. Arrowhead was open that year and had, I believe there was a few days that we only had 1 or 2 open rooms in the entire campus. So that was much different than what we're seeing now. And we don't anticipate that happening again. Since then, we have been budgeting full just because there was guidance to budget as though COVID was not a thing because we didn't know when it was going to end. I think we are wiser now that it's not going back to what it had been before at this point due to staffing shortages. So our ideas are to either have 2 or 1 household closed as part of the budget, which would affect our income, obviously, and then also what we budget for expenses. So don't know if anyone has ideas or thoughts on that as well.
I guess I can. So full is unrealistic, maybe 2 houses closed is too pessimistic. I guess I'd opt for 1,
Okay.
go the middle road.
He said that being full is maybe too optimistic, but having 2 closed is
Oh,
too
okay.
pessimistic.
Yeah,
So 1 closed was his suggestion.
Yeah, I wish Sean were here. I'm sure he would have some ideas as a business guy. I'm looking, first of all, we wouldn't lose any beds. We still have to pay our bed tax and so forth.
Correct. As of now, that is another discussion that if we would like to have that, I would say for that one, we would want an action item. This was more as a discussion if we were going to discuss actually delicensing any of the beds, we would have to have an action item on that, on a future agenda.
But that's not what we're discussing at all. Okay, I just wanted to make sure on that.
I do have some census information from in the history. As Carmen said, in 2019, our average census campus-wide was 89.8%. So we through the whole year, when people came and left, it was an average of basically 90%. That was the good year. And then in 2020, the average census was 87.5. And like a hotel, you don't ever get 100% because there's going to be transitions. In 2021, when COVID hit, when actually started in 2020, I think, the average census overall for the entire year was 76%. And then it dropped in 2022 to 72.5. And that's when we had 1 to 2 households closed. Currently, we're at 70.4%.
Correct. So for households closing comparisons, this year, both households have been closed the whole year. 2022, they were closed the majority of the year. Both of them together were both closed. 2021, 1 household was closed. And then 2020, it was split. We had the whole campus open for part of the year, and then it closed, 1 household closed part of that, and then 19, the whole campus was open.
So your 2 households that are closed, do they have got about the same amount of people in each one? That
Yeah, 1 has 16 and 1 has 13.
13, okay.
if you don't use a bed for, say, a whole year, do you still have to pay a tax on it?
We do,
Oh, you do, unless you de-license it.
correct.
Hmm. And then say you de-license it a month later, could you?
No.
You can't, okay.
So the state of Wisconsin has a weird law that is a consortium on nursing home beds that they are not creating any new nursing home beds. So if we de-license a bed, we will not get it back
Hmm. Gee, that's-
currently.
that's
It
kind of
was,
strange.
yeah. So the only way to hold the beds is to sell beds. But then we wouldn't have them. But you could sell them, which is a whole nother
Hmm.
process, but if you de-license them, they do not come back. The state lowers numbers of beds. It was in draft of the budget this year to get rid of that law, but it was pulled out as it is policy, not budget for the state budget.
So with those two households closed, how much would you say that we've lost already from January until what's April financially? Do we have kind of an idea how much we've lost in?
That's a little bit, we can do a guesstimate, but it's a
Yeah.
little bit hard to determine because every bed could have a different payer source.
Mhm.
So it depends on who is in those beds. But I would say when we look at our revenue lines, across the board, the part that's off budget would give you that number. So if you look at the overall budget and show, how far down we are on revenue, that would be that number. But it also opening them does have costs too, so with staffing. So it wouldn't just be a benefit to open them, it could potentially be a cost as well.
And right now we are full. You know, basically we're full with what we're open.
Close to, yes.
Yeah, so you said 72%, 70%, and if they were totally full and they're all equal, it'd be 7/9 again,
Yep.
right? That'd be 78% or
Yep.
77. You certainly are. It's up to the chairman.
Carmen, how confident are you that you could staff 8 households if you did open one in addition to this one?
I think we are getting closer to that point.
Okay.
As Chris had mentioned, we do have had several internal interviews recently, as well as we have had quite a few people come back. I think it's sad to say, but with other nursing homes closing and delicensing, it gives us better odds of finding staff. I think we're heading in the right direction. I would not say that I'm 100% confident we can staff them. As we've seen with COVID and everything else, things change rapidly. And it could end up going the other direction, but, I also hate to say this, but sometimes a recession can be good for places like nursing homes for staffing. It's not good for everybody's personal pocketbooks, but it does increase people, push them into the workforce. So we might have luck with that as well. It's not great for the economy, but it might be helpful for us. So I think we are currently heading in the right direction to open another household. But as Supervisor Keeter had said, I think 2 is unrealistic. My personal opinion.
Yeah, thank you, Dr. Brown. Feel free to ask questions. That was a good one.
One other option for budgeting, if you want to have the one household open or just one closed, do you want that for the whole year or do you want to have a percentage of that even? Is it realistic to open an entire household January of 2024? Or would a partial year be better, be more realistic?
So these are all things that you've been discussing and thinking, huh?
Thinking, and we need guidance from the committee so we can get our budgets, the rough drafts done. And of course, it'll end up being, we'll use tax levy. That's the downfall of this realistic budgeting. But now that COVID's over, we have to be realistic.
Yeah, we have had the discussion before and sounds like 1 is what you would recommend. Is that correct?
That is what I would recommend, is having 1 closed. It does also aid in the fact of that year that we had a lot of residents that we weren't anticipating, was very difficult when it came to, we hit budget errors in, I believe it was June. So we were over budget already in June, but not over expenses. So expenses to revenue, we were still doing really well, but because of how our system works and things, it does cause issues when we do better than what we anticipated to, which is somewhat of an issue.
And if
but-
we end up opening 2 units and everything is fine, we could ask the county for a budget adjustment to avoid those financial SAP issues.
So say you start out with one house closed and or even 2, for instance, and say in the middle of the year, you see that things are happening that you're gonna have to, you can fill up the whole place. That's bad for the budget then too, or?
It just causes some logistic issues,
Oh,
but
okay.
it's nothing that we can't work through. We've done it in the past.
I mean, you could do it.
Mhm.
I mean, it's not illegal or anything.
No,
Right.
no, we could do it.
Okay,
It's just a few more keystrokes, a
Yeah.
lot more, but
Okay.
we know now how to make that easier.
Okay.
Okay, and this is just budgeting. In the past, we went by percentage
Mhm.
and yeah, why don't you go with one? That seems like an easy way to do it all year long.
Mhm.
You make adjustments as needed. Sarah, you looking the same way too? Yeah?
And then the other units wouldn't be budgeted at 100% because that's, you never get 100% for the whole year, but
Mhm.
some like 90% maybe on the other open beds.
Mhm.
This year, the budget comes back also to the committee, doesn't it? When you have a budget.
Correct.
And is that just for us to look at? I can't quite recall what Chris said. Is it,
Chris is online right now, actually.
It's for approval.
for approval? Okay, thank you, Chris. I feel like big brother or big sister is there. You're always there.
I'm recording you. Oh, wait, no, that's Zoom that's recording you.
Okay, so
When we get to that point, would you like just the 1 week notice of the budget? Or do you need more time to review what we send out?
No, I
Do-
don't.
do it the normal way.
I don't understand.
Normal?
either we're gonna look at it or not, we're gonna
I'm not an
understand it or
accountant,
not.
so
Yeah.
I even get confused with the parentheses where.
Oh,
Yes, that is difficult.
that's off, is it? Yeah, okay, we won't. Anyway, so you, okay?
All right, that concludes my report unless anybody has any other questions specifically for me.
It's related to this budget, it isn't really this, but perception is something I think we need to be considering. Perception of what we're doing, and I know Chris is listening, information, especially for supervisors, because I'm getting more and more, why don't we sell it? And I'm getting a lot of that they don't really know what's going on. You know, they don't know if we sold it, it'd go away.
Mhm.
I know that's what would happen. And with the money that we're gonna be spending this year out of the levy, we're gonna have more questions.
Mhm.
So I think it's important that we get information out there and give people the information so that they can look at it in a logical way, not, well, they said they were gonna pay for it 10 years ago as they went. I'm still getting that. But you don't want to say too much because you know, so just keep that in mind. And Chris too, I'm working good with that information and openness. That's important. That's,
Chair Kinnear, can I offer a comment?
you sure can.
So, Carmen, Beata, Jane, and I have been working since the first of the year, actually, on both trying to get a really solid handle on where we've been and where we're going in terms of some historical numbers and then some forecasting. And then we're also very cognizant of that messaging piece. And we know that it looks like now, because we're in the first year with a new auditor, we probably won't come out with audit reports until into July. And that's sort of our target date of knowing for ourselves where we're at, and then being able to start to determine what the message would be. Is the last year or this year, are they anomalies, or are they the shape of things to come? If we were to open all of the houses, how would that impact things? If nothing changed, what would that look like? You know, just some very tangible touch points for people around what we know, what we believe we can accurately forecast, and then what just is totally unknown. So our target again is kind of mid-year before the audit report is released for 2022, which will highlight the fact that it was not a profitable year.
Yeah, thank you, Chris. It's also nice to know, I've known this, but I know you're working on it. But other supervisors don't until I tell them. And I don't know exactly what you're working on, although I have an idea like you just mentioned. So that's always good to know. You know, they're saying, have you tried this? Have you tried that? And I emailed you on a few things just to share with that. And I've tried to give them information, but so that's great. I'm glad you're doing that. And the rest of them need to know that we have done really well at times. So thank you, Chris, also for always attending. Anything else before we go on to Jane? No.
Okay, here's the news, huh? The vouchers in your packet are in the back from how I printed it. Are there any questions on the vouchers? They look a little bit in a different format this time. I put them in a pivot chart, so they're a little more condensed. No questions on,
They're still there and we don't have all those other kind of numbers over on the side and
right,
they're nice. They're good.
okay.
Corley? No? Okay.
I summarize the types of expenses pretty well. Okay. So the first bar graph is the campus aging summary. How we're doing on collecting the money that's posted as revenue. On the very right-hand side, if you go to that last bar, the blue got higher, so that's a good thing. It's all current. And the other items are smaller, so that's good. The old stuff is smaller and the newer billing is what we're working on.
Questions?
Okay. The census that we have discussed, it's hovering at about 71%. Private pay is at 11%. Medicare is at 11%. I think Carmen and her staff are really trying to get those Medicare days higher, and that is an angle to make us a little more profitable at this point, and the VA is at 6%.
So the rest is Medicaid?
Yep, the Medicaid is 71% of our census, and that keeps increasing every year. The trend is over the years to have a higher Medicaid census. There's just not the private pay people out there. The cost of medical care is high. So that's what we've seen, and that's how we'll use that trend when we budget for the payer mix as far as our percentage of what rooms will be, how many rooms are we budgeting revenue for at what level.
I will also add that next month on our agenda, and it'll most likely be an action item, is a recommendation for the actual rate for private pay for 2024. Historically, we have gone up by about a 2% increase. That was also when inflation was at 2%. As everyone is aware, that is no longer reality. So talking about what our private pay rate should be for next year will be on next month's agenda.
Supervisor Keeter, yeah.
I was just wondering, roughly, do you keep track of people on Medicaid who came in paying their own way and then they ran out of money? Is there a number for that, or
We haven't tracked.
you haven't
that.
tracked that? Okay.
No.
We could figure that out
Yeah.
by doing an audit just based on people who've changed payer sources, but we haven't historically tracked that.
Okay. Well, I was just curious if you did have that. I imagine there are some that happens, that they start out and then they run out.
Yeah, I think there's maybe a couple every month or two that
Mhm.
transition like that.
Okay.
Because then in finance, we kind of work with those people to make sure that the dollars aren't overspent or underspent and nobody ends up short.
Mhm.
So we do work with those people.
Do
Yeah.
we see more vet VAs here so that there's more veterans here? Are there getting to be more veterans that are here at Neighbors?
Right
Because-
now, there are, it fluctuates up and down,
Okay.
and there's no rhyme or reason to
And what's
to trending that.
And what's listed on the census as veterans is only people who are paid for by veterans insurance.
Okay.
For us, we do have significantly more veterans on campus that just do not have them as a payer source. Just because someone was a veteran does not qualify them necessarily for nursing home care through VA. So we do have quite a few veterans that aren't listed under VA as a payer source, so.
Okay,
Then moving on to the numbers, the financials. The first spreadsheet on page 105, at the bottom it says 105. So at the top, the intergovernmental is the supplemental payment money that the state provides county nursing homes for trying to make them whole on their allowed costs that aren't paid for by the Medicaid rate. Now, the Medicaid rate has gone up substantially for 2 of our 3 buildings, and we got our final rates yesterday. So next month, we'll be making some adjustments to the Medicaid rate, but we do not know what the supplemental payment will be starting July 2023 and forward. So we're just projecting what we put in the budget.
okay, will that go down as the Medicaid rates go up?
That is the sense that I'm getting. I mean, that would be logical, but we still have losses
Yeah.
on our per day costs, the nursing costs and the food costs and all that is something that they can reimburse us for to make us full. So we'll see how they do their math at the state.
And that is, so as we've talked over the past few months, was something that was, I don't know if I want to say messed up. There was issues with for the December payment because it is a twice annual payment, December and end of June. It is something that WAC, which is the Wisconsin's Association for County Homes, has focused a lot on because there were several county homes that got much less than what they anticipated. We were one of them that got less than. There's some people that were even worse off than us, some counties. So WAC is holding a meeting this month or early next month that I will be in attendance with, that also will have the people who set these intergovernmental transfers at it, which they were at the last one. And it didn't go so well, but hopefully this one will go better as they are further through the process and can have more information for us as well. So hopefully soon to come, there might be more information on that.
Okay. Yeah, next line.
Next slide.
Yeah.
Revenue from public charges, that's what we are billing out for the room and board and Medicare B kind of things. So Supervisor Corley, you asked about how far are we to date. If we go to that total 2023 actuals and follow that line down, that's how much we've lost to date. Okay, so we are at 3.8 million in revenue through April, and that projects out to an 11.4 million. Next month, it might look a little bit better because the rates for Medicare or Medicaid will be computed and included in these financials. So it might go up a tad, but I don't expect a dramatic change. So we're at less than that we budgeted. We budgeted for a revenue of 13.5 and we're coming in at 11.4 as a projection. So we're behind in our revenues. So we projected as 100% open as we were instructed. Miscellaneous revenue is the senior meals and some land rent, and that is coming in not as what we budgeted, but the expense isn't there either. So that should net out okay. Interest income, it's minor. Donations for budgeting, the 68,000, that is in deferred revenue right now. It's not in our revenues. That's why you only see $125 there. When we buy the van, then that money will go from deferred revenue to true revenue, non-operating, and it'll flush itself out. Expense, salary and fringe, that is all salary and fringe. That's Carmen and social workers and more than just the nursing. So that's the total. We've got an projected 6.9 and a 5.5 for agency staff, which is higher than projected. Between the two, the salary and fringe and the agency staff, we're projecting at 12.5 million expense, and we budgeted at 11.1. So salary and fringe and agency staff is truly that extra million of expected expense.
Say that part again. I couldn't find the numbers.
Okay, so if we combine the agency staff and this all salary and fringe,
Okay.
Oh,
those
Gotcha.
two lines, then we're
Mhm.
short the $1 million.
Okay.
Operating expenses, we did review, Carmen and I and Beata in detail. We broke out some departments and some specific, like supplies, and compared it to census and projections. And we did find that Carmen's staff are managing, the supplies are down to the same level that the census is down. So there's no waste that I can see. So we're running a tight machine. As far as the operating expenses go. Depreciation is there, and then the CIP expense hasn't been used yet this year. That includes the bus and some other items that Scott might be able to speak to, the water. I don't know what you call those pumps.
The water to water heat pumps.
So are those projected to be purchased? Are we still purchasing those?
At this point, we are not planning to purchase those.
So we could adjust that a little bit for next month. And then at the bottom, if we take out depreciation expense, we have a net without depreciation loss of $3,023,000
Projected.
projected.
Yeah.
Yeah, not year to date. No. And as Carmen says, the staffing, excuse me, is turning around a little bit. So that number is still very fluid, very, very fluid. With higher direct staffing, every person that they hire direct versus agency is a savings. So that could really change the outlook. But this is pretty much the worst case scenario, and we're expecting it to improve.
Any questions, Don or Corley?
And if we want to look at the details of some of the nursing expense, we go on to page 3 of 5, where we have the breakout between CNAs, RNs, and LPNs. Again, that's very fluid. Chris told us there's only one position right now filled with a agency staff RN. So we see the RN amounts, going down as over time here. The CNA category is the most expensive. The grand total projected of 5.5 million. And the budget for that is a mixed budget, because we're spending less in nursing staff, so we spend more in agency staff. The direct staff at the bottom, it says nursing pool staff financial report. It didn't hold my change. It should say nursing direct staff.
Okay, I was wondering about that.
Yeah,
Okay.
yeah.
Okay.
I did see that. I changed it. It must not have held. I'll work with Beata on those fields. But that is a projection of 5 million there. And the budget was 8 million. So of course that's down when the agency staff is up. They balance in a way. They offset each other, I think is the
Mhm.
correct word. Any questions on the nursing staff?
I was just wondering, is the agency staffing one of the main problems for deficits? Say in an ideal world, you'd have all the CNAs and nurses hired full-time. Would we be in the black then, maybe?
Close. Yeah.
Close? Okay.
Between, I mean, in a perfect world, if we had all internal staff
Mhm.
and enough internal staff to open the other households, yes, we would be.
That would be.
So it's between the revenue loss of the households being closed and the cost of agency staff. But currently, to open those households, it would mean hiring more agency staff and adding to that expense.
Okay.
So those two things are what driving the loss.
And when you get that report,
Mhm.
it'll show, I think, that you were making money, cash
Correct.
flow wise anyway, for years.
Correct.
Yeah, it was darn near full, 135, one,
Mhm.
yeah, okay.
Mhm.
I like the way you put this together.
Mm-hmm.
And now that you changed that pool staff on the bottom, I'm not totally confused.
Right,
I
right.
don't understand it again. I tried so hard.
We're getting better. We're getting
No,
better.
I'm, I'll give you a hard time.
That we're always, tweaking a little bit of a few lines here and there. Okay, going on then to page 4 of 5. It didn't quite fit on the other page. This is the all nursing staff, everything together. Is that what this other one was too? That was just direct and this is combined.
Okay,
And there is a typo on that. There's a problem in a field on the line of central nursing. The total projected didn't carry through. That number is not 727,965. It is 2,232,000. So the total projected is 10,803,000. And I'm sorry about that.
so about 1.4 over the budget.
Mhm.
Makes sense.
Yep.
And the only caveat to that is the budget fully staffed. So in theory, it would be actually higher if we had staff. So the budget number is based on having all 9 households open. So just to be clear,
So the projected would be way higher.
correct.
Yeah.
Yep.
Gotcha.
The
Thank you.
cost per person, per resident per day is much higher than we projected because of that agency staffing issue. Okay.
Okay,
And then page 5 of 5 in the packet says senior meals. They're a little bit under what we projected during COVID. It kept increasing. So we went with that trend. And now the number of meals per day is lower. It's just hitting another wave. But it's still profitable. It's still a service to provide to the community, and it's not hurting the facility at all by having that. Appreciation, is there any questions on either of those?
it doesn't look like it.
That concludes the financial report.
Any final questions? Anything you can think of? Well, then I would take a motion to accept the final report or the financial report.
I'll move.
Coralie first,
Okay.
Don second.
Okay.
All in favor?
Aye.
Aye. We accept it. You do a nice job. And this is easier than it used to be, I hope. And it certainly is all the information we can handle.
Mhm.
Okay.
Yeah, good job.
Okay, so. Are we down the next meeting time date?
June 22nd. If that works for everybody at 9 a.m.
No announcements, no, nothing else? Great, we are adjourned.